Thank you for joining us today. My name is Carissa Charles, and I serve as the Director of Programming at Heart Valve Voice US, and I'm moderating today's webinar. This webinar will be recorded and will be uploaded to our YouTube channel shortly afterwards. As you may know, June is National Cancer Survivors Month. According to the National Cancer Institute, there are more than 18 million people in the United States who are cancer survivors. A recent analysis of the Surveillance Epidemiology and Result database conducted by the American College of Cardiology discovered that vascular and metabolic issues can manifest during or after cancer therapy due to treatment-related toxicities. This is also known as cardiac lead effects. Cancer survivors may not have symptoms of heart disease, but it may still be present and underdiagnosed. Today, we will hear from our panelists who will discuss steps that can be taken to identify risk factors and the need for surveillance for at-risk cancer survivors. Now, let's introduce today's panelists. Donnette Smith serves as the president of Heart Valve Voice US. She began her career in 1966 with the George C. Marshall Space Flight Center, National Aeronautics and Space Administration, where she worked under the leadership of Dr. Werner von Braun and was a member of the Saturn V rocket team. She later transferred to the U.S. Army Missile Command as a technical writer, where she continued until her retirement in 1999. Though representing patients after her second heart surgery in 1994, Donnette became the founding president of Mended Hearts Huntsville Chapter 260 and has served as chapter vice president, treasurer, and visiting chairperson. On the national level, she served as treasurer and executive vice president for 2 terms each. She has also served as the Mended Hearts representative for projects such as the I Heart Flu Shots campaign, the Hearts in Harmony campaign, and Dr. Barb Arnott and Speak from the Heart campaign with Gilead Sciences. She has also served as the patient's voice for several writing groups with the American College of Cardiology. Donna's greatest joy is attending sports activities with her grandchildren and participates in golf, tennis, and football and basketball. Welcome, Donnette.
Thank
And we'll turn over to Dr. Mark Russo, who is a professor of surgery, chief of cardiac surgery, and director of structural heart disease at Rutgers Robert Wood Johnson Medical School. An internationally known expert in the treatment of heart valve disease, Dr. Russo is one of the few heart doctors in the United States skilled at open heart, minimally invasive, and catheter-based therapies. He specializes in complex and reoperative aortic and valvular surgeries. Dr. Russo is among the most experienced transcatheter valve surgeon in the U.S. and is also an experienced heart transplant surgeon, participating in over 500 successful organ transplants. Dr. Russo is also a leader in minimalist and enhanced recovery and lean strategies, which focus on less invasive treatments and optimizing workflow to minimize pain, limit resource use, hospital stay, and provide the fastest possible recovery for patients. Thank you for joining us, Dr. Russo. And last but not least is Faith Dieter, who is a licensed marriage and family therapist, author, and online course creator. With a career dedicated to mental health and teaching people how to build healthy relationships, Faith has taught courses in men's federal prisons, provided continuing education to local law enforcement, facilitated workshops for at-risk teens across the United States, and pioneered one of the first therapeutic horseback riding programs on California's Central Coast. In 1992, 20-year-old Faith was diagnosed with Hodgkin's lymphoma and underwent chemotherapy and radiation treatment. After many years of good health, she discovered about a year ago that her heart was severely damaged from the treatment. Understanding she needed specialized care as a cancer survivor, she traveled to the Cleveland Clinic, which is a radiation heart disease specialty, and received a biologic bovine valve via TAVR. This experience had led Faith to educate herself about the long-term after effects of cancer treatment, a journey that continues as she navigates ongoing health challenges. Additionally, Faith now facilitates a free monthly support group for Hodgkin's lymphoma and has since since a cow helped save her life, she recently started a nonprofit dedicated to saving beef cattle from slaughter. So thank you, Faith, and we can turn and let's get this webinar started. So let's kick the conversation off to you, Dr. Russo. Can you provide us with a brief overview of valve disease and why cardiac lead effects may occur?
Yeah, so when you think about the treatment of cancers and how those treatments can negatively impact the heart valves, there's 2 different types of therapies that are the most common culprits. So one is that is radiation. And the radiation can cause damage to the heart in 2 different ways. The first is that it can directly impact the heart valve tissues, causing fibrosis, scarring, calcification, which damage the heart valve tissue and cause it to not function properly. The other possibility is that there's secondary damage I'm sorry, it's the damage is secondary to either damage that the radiation causes to surrounding tissue or the vasculature that actually supplies blood to the valve leaflets. And then the second class is chemotherapy. So chemotherapy can be directly, just like with the radiation, being directly toxic to the tissues, causing scarring and fibrosis. Another possibility is that you can cause damage to the heart muscle. So it's not necessarily intuitive, but because the heart valves are supported by the heart muscle, if there's damage to the heart muscle, that can cause secondary damage to the valves and lead to dysfunction. You can also have damage to so when we talked about the damage to vascular supply to the leaflets, those are microvascular damage. There's more macroscopic damage that can occur, particularly to the coronary arteries, leading to calcification specifically of the coronary arteries. And again, that can lead to damage to the heart muscle, which leads to damage to the valves. The last one is that there can be oxidative damage. So basically, the inflammatory process of the drugs leads to inflammatory process around the surrounding tissues, again, damaging the tissues and leading to dysfunction.
Excellent. Thank you, Dr. Russo. And we'll turn it over to Donnette and Faith to share more about their journeys with valve disease. So let's start with you, Donnette.
Absolutely. I'm always glad to share my story, but I've had heart valve disease since I was born. I was born with a bicuspid aortic valve, so I knew from my teenage years that eventually I was going to have heart surgery. So I have, and in the process over the years, I've had 5 open heart surgeries. In 1996, I had started having issues that I didn't really recognize, and it was the doctors were watching it. I was short of breath, hard to walk across the floor without losing my breath. I had asked when I was diagnosed with breast cancer if I had any kind of heart disease, so I went to my surgeon and I said, okay, I'm going to have radiation. I've decided to have radiation. And I said, will it affect my valve? I had a mechanical valve at that point. And he said, no, they will aim the beam away from your heart or any major organ, so it'll be fine. And so I went through with like 7 weeks of radiation, and it really exhausted me going through all that. And when it was finished, I thought, I'm good, I'm good to go. And so I went ahead with my life. And then I started having issues. It was several years later that I started having issues again. And when they would do an echocardiogram, they could see that there was tissue floating in the blood. And so, which was kind of like, what is that? I could see it myself. And so nobody really knew what it was. And so in 2009, I was back in heart failure again. And it was really a difficult time, that since we didn't really know what was going on. And so they sent me to to Nashville, to Vanderbilt hospital there, and did some tests and found out that one side of my mechanical valve had clotted shut. And they were like, we don't know what to do. There's no way we can do surgery on you again. So I wound up getting an apical aortic shunt, which went from the ventricle to down to the descending aorta, and it had a pig valve in it. And it was like, wow, had no idea this was even possible. But I managed to get through it and to thrive, and I'm doing really well. Although 3 years ago, I had started having issues again and discovered that the pig valve in the shunt had disintegrated. So all this was caused, they've decided now from the radiation that I had, and it caused damage to the heart. Um, I'm doing well from that. I'm now battling cancer again, and I'm on chemotherapy. So we're watching the heart really closely, and so far so good. Um, un- Unfortunately, in 2011, my sister, who was my youngest sister, who was age 44, was started getting really sick, and she started gaining lots of weight, retaining fluid, and was misdiagnosed with having food poisoning, pneumonia. I mean, we went through the whole gamut, and I said, no, she's in congestive heart failure. You could see it. And she had had breast cancer. She was diagnosed after I was, because, they tested my female siblings after I was diagnosed. And so she was diagnosed with breast cancer at age 33. And so she had 3 small children, and she wanted to do everything she could to stay alive, and to take care of them. And it was, she wanted to do everything. So she had a bilateral mastectomy. She had chemotherapy. She had reconstruction. She did it all to hopefully stay healthy. And she did for about 10 years. And then at the 10-year mark, she started having issues again. As I said, she started swelling and having shortness of breath. She couldn't breathe. Um, to make it a little bit shorter, because it was a long journey, she developed cardiomyopathy. She had valve disease. When they finally diagnosed what was going on with her, she had major damage to her organs. She was in liver failure, kidney failure, all that, and there was just nothing they could do. So she passed away at age 44, and I made it my mission to find out why. And so I started going to the um, uh, events that would have survivor walks, like the breast cancer walks. So I would walk with the survivors, and I started asking those women, were you told that there was any possibility that you could have heart damage from your cancer treatment? And they were like, no, nobody told me that. I thought I was done, and that really bothered me, that women were not being educated on the possibility. And I said, all it takes is just, after you finish your treatment, get an appointment with a cardiologist and start being watched, to make sure that there's no damage done. And I took every opportunity I could to ask people. I asked surgeons, I asked cardiologists, I asked anybody that I could get to stop and listen to me, and let them know that this needs to be addressed. I was told that there was no research being done on the connection between cancer and heart disease, and I could not accept that. So I enlisted the help of someone at the American College of Cardiology, and she started doing some research, and I lost track of her over the years, but you can imagine how excited I was when I found out that there is now a subspecialty with ACC, and it's cardio-oncology. And wow, was that a blessing. So I'm excited for this webinar, because we're getting the message out to people, and that's so important. Thank you.
Excellent. Thank you so much, Johnette, for sharing your story. And we really applaud you being here today and raising awareness on this topic. And let's turn to you, Faith. We'd love to hear more about your journey as well.
Okay. So my journey began right around 1992. I was 20 years old, but it actually began 2 years before that, because I was starting to have kind of strange symptoms of trouble breathing when I was jogging. I was very athletic and fit at the time. I was on the UCSB cycling team, and like I would start out well, and then I would just sort of crash. And when I would go to the doctor would say, well, you couldn't be doing as well as you're doing if there was really anything wrong with you. So he gave me like an inhaler for exercise-induced asthma, which I didn't have, and just some other things. And I would go home, and then the symptoms began to change over time to where I started having funny chest pains when I would wake up in the morning, but then it would go away. And then I would have this funny little cough that I sort of didn't even notice anymore, but friends of mine would say, "You cough all the time." And so finally I had severe chest pain after about 2 years. And I went to a different doctor, and that doctor also told me, it's really highly likely that there's really nothing wrong with you. But she said, just to be on the safe side, let's take a chest x-ray. And the kind of ironic part is the first doctor meant well. He kept saying to me, I don't want to expose you to radiation that you don't need with this chest x-ray. But the chest x-ray is what found the tumor, which by that point was about the size of a cantaloupe in my chest wall. It was pushing my heart over, squishing my lung down, and spreading my ribs. So that started me on the journey of finding treatment for Hodgkin's lymphoma. We found Stanford in California. I live in California. I was on a program called Stanford 5, which the idea of that was to have fewer of the chemotherapy drugs that Dr. Russo is talking about, and smaller amounts, more drugs, but smaller amounts of each one, so that ideally the longer toxic effect could be reduced. I don't know, as compared with today's standards, how it compares, but sorry about that, my rooster. So anyway, I did get chemotherapy. I did get radiation treatment. At the time, they did tell me that the radiation could damage my heart, but they said that it was a necessary thing I needed to do to save my life from the cancer. They put some lead shields up over the radiation to try to protect me. Fast forward all these years later, I've been fine. Unfortunately for me, I've been going to my annual cancer checkup, just like you were saying. When it comes to what people have been focused on, it's watching me for breast cancer, lung cancer, secondary leukemias. That has been the focus. And so it was just when I went to my college urgent care one day as a young person that the doctor said, you've had Hodgkin's lymphoma. By the way, one of these days down the road, don't worry, it won't be for a long time. You're going to need a new heart valve. He's the person that alerted me, not my oncologist. In fact, we never watched me for that. So at some point in my future, it was my mother that forced me to start seeing a cardiologist, because I was like, I'm fine now, I don't need that. But the cardiologist saw a little bit of stenosis, but what I didn't realize was how fast the stenosis would progress. I had it in my head that I would maybe need a new heart valve when I was about 80. I think that's what the first doctor might have said, that the one at the urgent care. But I was 51 last year when all of a sudden my valve went to severe, and I needed to have a heart valve replacement like very quickly. And so I wasn't prepared for my education. I wasn't prepared about what options were available to me or not. As a cancer survivor with the radiated tissue, it's a little different for people like me than it is for people that haven't been radiated. I wasn't prepared mentally or emotionally. And so it just started a whirlwind procedure to very quickly seek out the best medical care that I could find. I traveled to the Cleveland Clinic, which I'm very glad that I did go there. I felt confident. So for part of my journey was to have confidence in the doctors that were helping me. And I gave my trust to the doctors there because I had the confidence to do so. And fortunately for me, I was able to get the TAVR valve procedure. The other problems that can happen, like the coronary artery disease, I was cleared so far of that. So I was able to get the TAVR. I got the TAVR. It was much easier physically than I ever dreamed it would be. It was mentally and emotionally, in hindsight, that I think I struggled the most. I think I actually struggled more than I needed to, mentally and emotionally, during this whole thing, because I was so afraid. But as it turns out, things went great. I did have some complications after the surgery because people called TAVR easy peasy, which I suppose compared to other things, it really is. But I did get a left bundle branch block that has actually resolved itself. So that actually got better. And I did develop a blood clot later on my valve, which wasn't expected. And I was very afraid of getting a mechanical valve because of my horseback riding and the blood thinners. But as it turned out, I'm on a blood thinner now, temporarily, and no longer riding my horses because I did develop a clot. So I feel like a couple of things are important from what I learned, which is to make sure you advocate for yourself. And if you feel like there's something the matter with you, to maybe find another doctor to try a second opinion so that you can find out what it is or not. And also to just be aware that as wonderful as TAVR is, and it is, there are still some secondary effects that are important to be on the lookout for so that they're not missed.
Thank you. And that's such a great takeaway to always seek a second opinion. And we'll definitely touch more on that, on what you should do in order to get the most out of your care team experience. But if you are just now tuning in for our audience, we just had a great overview on the link between valve disease and cancer treatment. And we definitely encourage you to submit your questions for the panelists, and all questions will be answered toward the end of the webinar. But now I'll turn it over back to you, Dr. Russo. Can you provide us with more insights on how valve disease is diagnosed, as well as the available treatment options?
Yeah, so just to highlight a couple of things, and these are a couple issues that came up in describing your own experiences. First, if you need to undergo cancer treatment, it's important to get baseline cardiac testing, so you understand if you develop progressive disease as a result of the chemo, if you're going to be on chemotherapy that's potentially cardiac toxic, and to make sure that you get follow up over time. A couple other important points were highlighted, that this is a relatively new field. It's probably one of the more rapidly evolving fields in cardiovascular disease, because there's so many people or I guess we now recognize the impact that this has on people. So I would definitely encourage anyone who potentially faces these issues to find somebody who really specializes in these areas, because there's more people in practice focused on the specific area, and it's a complex, again, rapidly evolving space. So you really want to have somebody who understands the issues and is gonna guide you. As far as the available therapies for heart valve therapy, it is still possible for us to do heart surgery on conventional heart surgery, where we make an incision in the chest, use the heart-lung machine, open the heart, for people who have had chemotherapy, radiation. But unfortunately, those things can often increase the risk of that option. So an alternative in the last 10 years or so is transcatheter valve therapies have become very widely available. So there's now over 100,000 TAVRs done annually in the US. It's one of the most common cardiovascular procedures that we perform. I did 4 today, and I was, and I'm here to talk to you right now. So, and again, not to minimize the risk or the impact of those procedures, but they typically go well. They typically go quickly. People typically go home the next day, and they feel better. So those are totally disruptive therapies in the treatment of particularly valvular disease, because again, there's people who would not be great candidates for the traditional approach, which would be open heart surgery. One other thing that I would mention is, you had mentioned that I have a lot of experience in transplantation. So there's also, unfortunately, not just people develop cardiac disease, which may lead to valve disease, which may lead to heart failure, and ultimately people may progress to the point where they need heart failure therapies. Heart failure medications are improving. Transplant is, although not desirable, it is actually a great option for people, and it can really extend patients' lives, particularly those obviously who have very end stage disease. And there's other forms of mechanical support, left ventricular assist devices, which are modern day artificial hearts, essentially. And those, again, are very advanced therapies that fortunately most people will never need access to. But there is a breadth of therapies that have become very widely available just in the last decade for patients who are in need.
Thank you. And of course, like the fact that you've done 4 today and are able to still participating in our webinar really just goes to show how minimally invasive it is. So that's definitely something to keep in mind for those who are watching online. But thank you again for sharing, Dr. Russo. Now we'll turn it back over to Dawnette and Faith. Based on your personal experience, how can patients start a conversation with their care team to gain a better understanding if they're at risk for bowel disease? And I'll start with you, Dawnette.
Okay, yeah, it's super important to talk to your doctor. That's where it starts. You've got to feel comfortable with the treatment that you're going to receive, and you've got to be comfortable with what's going to come down the line. You know, you need to know. So awareness of all this is so important, and I applaud Dr. Russo for his effort and saving lives and doing what's needed for the patients. And like I said before, the cardio oncology is so needed, and I'm so excited to see it now happening, that patients can be screened. And that's what I said from the get-go. You need to be screened before you have the treatment, and then watched afterwards. And so that was awesome. I'm so glad to hear that. But the patient just needs to be really aware of their own body. They need to know that it's okay to advocate for themselves. To if you're not comfortable with a treatment or anything before you start the treatment, speak up, say something. And I mean, it's your life, so you have the right. And that's the message that I try to get through to patients when I talk to them is please be aware of what's available. If you're not getting the answers, then go somewhere else. But ask the questions and be comfortable with it before you even start.
That's definitely something that patients should keep in mind. And what are your thoughts on this, Faith?
So I agree with Dawnette that having a good relationship with your doctor is key. And even if that means finding a different doctor that you may have a better relationship with, that's a possible, I needed to do that. My first doctor was a very good doctor, and I needed a lot of information, and I needed a lot of talking. And he wasn't a big talker, but my next doctor was. In fact, he talks more than I do, which I really appreciate. And so what I've learned to do is I write down a list of questions. I send it on the MyChart before my appointment. And then what I've learned how to do is print out 2 copies, not one, because when I was taking one copy with me, for some reason, I was putting into the situation that I had to rush through all the questions. The doctors weren't doing that. It was me doing that. And so I would find myself skipping over things that I actually wanted to know. So now what I do is I make 2 copies. I hand the other copy to the doctor, and I let the doctor take the lead and go through all my questions, because my doctor doesn't skip them like I do. And so another part on that is, I would say, to give yourself permission to give yourself the best care possible. I didn't need to think of myself like I was bothering my doctor, because I wasn't. But that's what I was doing, skipping over my questions. So to give yourself the self-respect, it's your life, to take the time you need to take. Get yourself as educated as possible. The online community has been life-changing. For me, I found Hodgkin's lymphoma survivor groups, and the other members in the groups who have been through these processes before I have been able to supplement my information, help me with what questions to ask. And the information is out there in a much more expanded way than it was in 1992, when I was going through the first cancer, the cancer situation that I was in. So I would just say that to really own your part in the process. I think of myself as a 3-part of a treatment team. I have my cardiologist, my local cardiologist. I have my Cleveland Clinic cardiologist that's still following me, and I have me. And the 3 of us together, in my mind, are the treatment team. And I need it to be like that, because I'm the one that's reporting the symptoms. I'm the one making the changes to ideally take the best care of myself I can, and they're guiding and directing me in order to do it. So to me, it's really important for me, the patient, to be a part of it.
Yes, definitely. That's definitely excellent information to have and present to our audience as well. And I don't believe we touched on this during our earlier conversations, but Dr. Russo, from your opinion, what are some of the best ways people can get screened for heart valve disease? I know echocardiograms are typically one of the easiest ways to get screened for heart valve disease, especially in the earlier stages. Can you give a brief overview on what echocardiograms are?
Yeah, well, even taking a step back, the stethoscope is sort of the most basic way to assess people. I don't think that's sufficient in 2024. As you pointed out, an echocardiogram, it's actually a tool that lets you see inside the heart. So if you have the opportunity to do that, then you should. And again, as has been pointed out a couple different times, if you're going to be facing therapies that are potentially cardiac toxic, if you and on top of it, if you have known cardiac disease, or if you have a strong history of family disease, all of these risk factors are important. So the first step is really to assess your risk based on the drugs, the duration, the dose, and again, your own history and your family history. Because obviously the higher the risk, the more closely you need to be followed. But yeah, everyone should get a baseline echo. It's a simple test. It just requires some gel on your chest. It's a little cold and uncomfortable for a couple minutes, but it's completely non-invasive, and is it provides a lot of information. And then the degree to which you need to be followed depends on some of the things that we just talked about. What are your existing risk factors? What's your family history? What's the risk based on the therapies that you're undergoing, and is disease seen? Is there progression? Is it progressing more rapidly? That would obviously require closer intervals of follow-up. And the last thing I would point out is that, and again, this is consistent with people's experience, that the risk doesn't end when the treatment ends, the oncologic treatment, that is. So people need to recognize that you can develop disease, months, years, even decades later. So the follow-up should continue, because it's typically not an instantaneous thing where you get cancer treatment and then you develop heart disease. It typically occurs over the period of at least months, but more likely years. And so people need long-term follow-up, not just during the period where they're being treated.
That's a great point to make. And thank you again for sharing. And Dr. Russo, just to piggyback on that, do you have any words of wisdom for individuals who are newly diagnosed with valve disease and want to ensure that they have an active role in the decision-making process with their care team?
Sorry, I would say the same thing is true, that it's closer follow-up, but just as in the case where you're being treated for cancer, and you want to have a cardiac oncologist, somebody who specializes in that area, who really has a strong knowledge base and interest and understands what the issues are. In the case of valve disease, there's a lot of people around the country who focus on valve disease. You can find experts in that area, and you should be followed over time, to make sure that you get expert follow-up and get directed to the right therapies if needed.
Great. And Donnette and Faith, what are your personal thoughts on this?
Um, absolutely. You need to be aware of your health, be aware of how you feel. If something's off, then definitely seek help for that. But most of all, if you're diagnosed with cancer and you're going into screening or treatment, stay on top of it, ask questions, educate yourself on it, and don't be embarrassed or afraid to talk to your doctor about it and demand answers. That's my key thing, is just don't be afraid. I know my mother lived to be 94, and she would not ask her doctor questions. And I said, Mother, why? And she says, because he's a doctor. And yes, older people tend to put them on a pedestal and are afraid to talk to them, but that's not the case. They're there to help. And so you need to be comfortable in talking with your doctor. Mine talks to me all the time. He knows how I am, and he knows if he doesn't answer the questions before I ask him, I'm going to ask him anyway. And that's helpful, and that's comforting to know that you have that connection, and you've got someone that has your back through this whole process. And even though I'm in chemo treatment right now, I know that my heart's being watched, even as damaged as it is, and And that makes me, gives me some peace to know that I'm not going to wake up one morning with something going on that might not can be fixed. And I wanted to say to Dr. Russo, thank you for all you do. I was just at MD Anderson in Houston for my cancer, and the doctors there, looking at my chart and all the surgeries that I've gone through, said you must really have a good care team with your physicians, because you, according to your chart, you really should not be here. And so I'm in awe of, I'm kind of like my mother. I'm in awe of my physicians, and I'm grateful for them taking care of me. And so thank you, Dr. Russo, for what you do.
Yeah, you shouldn't underestimate your role here. Trust me, you had the harder part.
Excellent. And Faith, any thoughts on that?
On screening? So yes, along with what has been said so far, which has been really good information, I would say to resist the temptation to take the easy route, because right now what I've noticed in healthcare in general is it's not always easy to get the test done. It's not easy to make the appointments. It's not easy to wait on hold for a long time with the phones. It's not easy to reach the people that you need to reach in order to get the appointments made. Then you have the health insurance side of life. And as a health insurance provider myself, as a mental marriage and family therapist, it's not always easy to navigate that system. And I actually have a reputation in my house for being someone who can stay on hold for like a long, long time. And that's the system that we're in right now. And the system will work if, what I would say is, if I do my part, back to my personal responsibility in the system, it can be easy to avoid the screening, because a lot of times there are hoops to jump through in order to get it done. But it's very important to get it done anyway, and allow yourself to be uncomfortable now so that you can hopefully be much more comfortable in the future.
True.
That's actually a really important point. In healthcare, we don't make it easy or it's easy for people. Well, we don't make it easy at all, but and it's, we have all these great therapies and we should make access to them. The barriers for people to get access to them to be less, but also, I would echo that it's really important, particularly when you're dealing with complex things like cancer, heart disease related to cancer therapy or heart valve disease. Those are not trivial issues, and you really want to find people who specialize and are focused in those areas. And sometimes that might require, making an extra phone call or driving, an extra 30 minutes or an hour, but it's worth your time.
Hmm.
And thank you all for sharing your thoughts and feedback on that. And if a patient is newly diagnosed with bowel disease following a cancer diagnosis, where can they turn for additional resources for support? I'll start with you, Donette.
Well, there are all sorts of support groups out there, and that's super, super important. I've been dealing with that since 1993, when I had my second heart surgery. I finally reached out to support groups, and they're there. They're there to support you. They're there to help you. They're there to answer questions, just to help you through the whole process. So I would certainly start with seeking out help through a support group of some kind, whether it be, there's cancer support groups. I'm in one now for a multiple myeloma, and it's been so helpful to understand what's going on now with me, because other people have gone through it. So I can't even explain it. It just means the world to know that somebody's been there and they've survived it and they can help you through it. So that would be the first place I would start, with seeking out to a support group.
Of course. And Dr. Russo or Faith, do you have any other ideas for resources for support?
Well, two already mentioned here, Mended Hearts and Heart Valve Voice are definitely, I think, two organizations that can be very helpful. There's professional organizations, the American Heart Association and ACC. They have patient-facing resources that people can provide, but to have people who have had the experience, who can share their own experience, that's probably as powerful as anything.
Great.
And I would say that one of the first steps is to just allow yourself to acknowledge that the mental, emotional side of this is just as real as the physical side, and that it's very normal to have a whole bunch of different emotions, sometimes conflicting emotions, from gratitude and relief to fear and frustration, maybe even anger, sadness. After a heart procedure is finished, there's talk among the community of depression that can sink in. And personally, I think that may occur because in front of the procedure, at least for myself, there was so much to figure out and do it quickly. It was almost like being in an accident. There's actually a term called medical PTSD, where you go through this semi-traumatic event in order to save your life, which is a good thing. But there are a lot of emotions that come along with that, and they can come in front of the procedure, but they can also come after the fact when you have the time and the relief and you're well enough now physically to be able to feel the feelings. So I would just say to embrace that process. Don't feel like there's anything the matter with you. I know I went through a lot of different emotions. I know my family went through a lot of different emotions. Don't forget that you're not the only person that's on this journey with you. The people that love and care about you, they go through a lot too.
Thank you. And that's great information and something definitely to keep in mind. And this portion will now turn over to our audience Q&A section. So if you have any questions for our panelists, feel free to put them in the Q&A section of the Zoom link chat. I'll turn it over to you, Dr. Russo, for this question. What percent of cancer patients who receive radiation therapy do you think develop heart disease or heart valve disease?
I don't know if anyone knows the answer to that. It is relatively low. I would say, in terms of percents, it's in the single digits. The real issue is what are your risk factors? Because again, if you're receiving therapies that are at higher risk, if you have pre-existing conditions, or if you have a strong family history, or if you have longer duration, all of those things are additive. So it's really it is patient specific, and that's why it's important to understand, to be risk stratified, and to find providers that really understand, and it can help you quantify the risk, so you can proceed accordingly.
Got it. Thank
It
you.
is worth, based on, it is, so there are certain conditions that are, for example, breast cancer is in patients who have breast cancer, then aortic stenosis is, a common sequelae of treatment. So there are certain diseases that are linked with the treatments, but it's hard to put a risk on it for, sort of a large population of people.
Definitely. Thank you. And this question from the audience is for you, Faith. What type of TAVR valve did you get?
I got an Edwards Lifesciences bovine tissue valve.
Great. Thank you. And this is more of a comment from one of our audience members, but they said this is fantastic information. They really enjoy the idea of printing 2 copies of questions to take in with them. And they thank you all for sharing this information. And this is an amazing webinar. So we appreciate that feedback. And another question we have from the audience is, are there certain chemo drugs that are more linked to development of cancer after lymphoma or breast cancer? And Dr. Russo, I believe you can answer this question the best.
I don't know if that's true. There are certain drugs. I I don't prescribe those drugs, so I wouldn't be the best person. But there are certain classes of drugs that are clearly at higher, that are associated with higher risks.
And I might be able to help as not a doctor. So I would just say, do your own research for what I am about to say. But one of the drugs that I received that I've been told by doctors is potentially damaging to the heart is a drug called adriamycin. And I believe that's in the classification of drugs that Dr. Russo is referring to. There's also a drug that sometimes people get in a chemotherapy called MOP that can actually apparently lead people to get more polyps in their colon, which could potentially increase colon cancer risk. So those are things to research on your own.
Thank you. That's definitely something to keep in mind. And last but not least, in our audience chat, we just got another question, but we have an audience question that says, I'm about to have radiation again in 6 months. I've had it twice before and resulted in the need for TAVR. And I'm at a larger risk for future radiation therapy. I know we can't really answer this definitely since we are not, we can't provide medical advice, but if anyone is on our panel is able to provide their insight on this, that would be great.
If the question is that is the existing valve more likely to deteriorate as a result of radiation, I
Yes.
would say that that's something that to be concerned about. You know, people who have a bioprosthetic valve should be followed regularly for valve degeneration regardless, but a person who's undergoing radiation should be followed more closely.
Definitely. Thank you. And another question we have, is there a very polite way of asking your doctor about cancer-related effects? I'm not sure many oncologists fall up to that degree. Donette, would you like to provide your insights?
Well, I'll just go with my experience. Don't be embarrassed or afraid to talk to your doctor. That's what they're there for. So be brave enough if that's what it takes to ask your question, but don't leave the office or the hospital, wherever you are, without getting your question. Definitely.
Yeah, I would also say that I would encourage people to get second opinions in cases where there's uncertainty or in complicated cases. You know, a physician shouldn't be insulted by that. A significant percentage of my patients are patients who see, you know, multiple different physicians. And my own personal experience dealing with potentially cardiotoxic drugs. I had a family member who was recommended for a certain type of therapy that would have put a very high risk for developing cardiac disease, and a different regimen was much more benign regimen was recommended, and 20 years later, you know, they're still alive and doing well. So you know, it's in these cases, the answer is not always clear. There's a lot, you know, as physicians, a lot of what we do is manage uncertainty, and you have to be comfortable with the fact that you don't always know the answer. So I would encourage people to get second opinions in these complicated cases.
Mhm. And I would say, remember that your doctor wants you to get better and do as well as you possibly can. Correct me if I'm wrong, but I believe most doctors or all doctors get into medicine because they are so driven to help people that they go to enormous lengths, time, effort, expense to go through all the efforts of education in order to do that. They're also under extreme loads of pressure. My sister is a doctor, and you know, she has to see a lot of patients in a short amount of time. So don't let the feeling that the doctor has a lot to do interfere with the understanding that as a therapist, like, I'm the happiest when my clients are happy. And I imagine as a doctor, your doctor is happy when you're happy. So just remember that everybody's on the same side here. We're all working on the same team, which is to be the recipient of the best outcome possible. So give your doctor the tool your doctor needs, which are your questions, so that your doctor can do their very best to be able to help you, because chances are that's what they want just as much as you do.
That's excellent advice. And we also have a comment in the chat about bringing a care partner to help you at your appointments. Sometimes they have a stronger voice and may not be intimidated to ask the hard questions. And Faith and Donna, I'm not sure if either of you have experience with bringing a care partner to appointments, to kind of shine light on that as well.
Yeah, my husband always went with me to my appointments, always. And I had my cardiologist, the one time that I went without him, he said, I can always tell if when my patients are doing well when they don't bring their partner with them. So definitely, yeah, it means a lot to have your partner there or have someone there. My husband has passed away 3 years ago, so I go to most of my appointments by myself now, but I know my doctor and he knows me. And so he's really careful to make sure that I understand what he's saying before I leave the office. Um, you need a second set of ears to listen, to make sure you're not missing some instructions that the doctor give you. So yes, definitely take a partner with you when you go for your visits.
And I want to speak to that also, because what I want people listening to know is that under stress, our brain changes the way it operates. And we get more into the emotional part of our brain, and we actually have less of the logical part of our brain available in under stress than we would normally. And that's where memory is stored. So if you've ever been in a situation or a doctor's appointment and you're right there in the conversation, and then you get to the parking lot and you can't remember just about anything that was discussed, that's not your fault. It's your brain under stress. So if you can, again, know this ahead of time, bring a person with you during some of the more technical conversations with my doctor. I asked his permission. I explained, I'm not going to be able to remember anything you've said when I walk out of here. Can I please record the conversation? He said, okay. That helped me also with consent and permission so that my brain could go ahead and do what it was going to do under stress, but then I could still get the information I needed. So having a second set of ears to help you process the information that's so important, absolutely.
And that's a great comment about recording the conversation, especially if you're unable to bring a care partner with you. So that's definitely something I hope people take away from this webinar as well. And we do have another question in the chat. For I believe this is for Faith as well as Donette. Was it ever discussed by your physicians that you may need to have a valve-in-valve procedure down the road?
Well, I was told after I got the mechanical valve, it was a St. Jude valve, that there was no way that I could have the TAVR done because it was a mechanical valve. And so after I got the shunt with the pig valve in it, I was told, okay, now if something goes wrong, we can do the TAVR, and that's exactly what happened. So I did get the TAVR, but until then, it was not an option.
For me, the valve-in-valve option was a big part of the conversation before I went ahead with any procedure at all. I was 51 when I had my valve get severe. So I was doing math. How do I get from this age to this age, and then from this age to this age? And at the same time, like I said, I was trying to preserve my quality of life, which the horses are a very big part of my life. And hitting your head, which you can do if you fall, and getting a brain bleed is a big risk factor. And so the valve-in-valve has been a really important part of the conversation. So yes, I would suggest for anyone who is looking at all these different options, make sure, maybe Dr. Russo can say more about this, but my doctor told me that the placement of the first valve was important so that the second valve could easily handle the valve-in-valve for a second run.
It depends on people's anatomy. For some people, that's not as much an issue. The bigger issue is making sure that that the valves that are placed are large enough that you can put other valves in them, and that also is specific to patient's anatomy. Some people just naturally or their valve is just small, even outside of the fact that it becomes stenotic. So that's the biggest consideration. It becomes a Russian doll phenomenon, for lack of a better analogy, where if you keep putting something inside it, the next thing you put inside it has to be smaller because it's going to be constrained by the previous valve. But there are issues sometimes where the valves can impinge on the coronary arteries or other adjacent structures. So that does have to be considered in some patients, depending on people's specific anatomy. And again, it goes back to why it's important to find people who spend time thinking about these things, because they're not necessarily obvious if you don't have a lot of experience dealing with those issues.
Thank you, and that's really helpful to know. And we do have time for one more question. How can I be referred to a cardio-oncologist? I can start with Faith, if you have any thoughts on that.
I do, because I'm going to go through the process myself. I imagine it depends on multiple factors of whether or not you need a referral. So I would say first and foremost, I would seek out a cardio oncologist. They may or may not be easy to find. I know for myself, I'm going to need to travel to a large city, which is going to be several hours away in order to where there is even one potentially available to me. So I need to find out if I need a referral. If I do need a referral, then I'm going to need to go to my health insurance company to sit on the phone and be on hold for a while and get a pre-authorization going, which so far in my experience, I've always been able to get. So again, don't let the work it takes dissuade you from doing it. And if that means I need to go to my oncologist or I need to go to a primary care doctor in order to receive a referral, then I'm going to need to do that. So back to, um, I guess, think of it like a research project. Pick up the phone and start the process, and you will find your way. If you don't know how to begin, take the first step, and that step will give you more information in order to take the next one and the next one. It may take you a while, but it's worth doing.
Definitely. Donna, any thoughts on that?
Yeah, I agree. It's you've got to take the first step. My only issue is that with all these steps, it's a little intimidating, especially for older people. And I'm not sure that they would have the energy to go through all that, like sitting on the phone and such. So if you've got a family member that can help you do that, then by all means reach out to them, or just start with your cardiologist or your family physician and say, this is what I want to do, and will you help me do it? And usually they will. So it's just important to, whatever stage in life you are, there's always a way to get it done. And just you just have to be patient. And I shouldn't even be saying that, because I'm not a patient person. When I want something done, I want it done now, and not yesterday or tomorrow. So it's just important to do it. Get help wherever you can. If it's a family member or your doctor, by all means, start somewhere and ask those questions.
Definitely. And Dr. Russo, do you have an opinion on that as well?
No, I think those are all great insights. The only thing I would suggest is, in a perfect world, you may want to find not so much a physician, but maybe a center that focuses on this, because again, there's a lot of different kinds of chemotherapy. There's different kinds of cancers. There's different kinds of cardiovascular disease, and so it's usually, the optimal care is probably not just provided by a single person, but by a team of people who have understanding of these different areas. Because again, there's a lot of complex relationships that occur here, and so it's difficult for one person to have all the knowledge to deal with them.
Excellent. Thank you so much for sharing that. And thank you everyone for tuning in to today's webinar. We have come to time when we are going to wrap up today. I would like to ask our panelists one final question. Is there one thing you would like patients or cardiologists or healthcare providers to know or do regarding the link between cancer treatments and bowel disease? I'll start with you, Faith.
Is there one thing to know? So for patients, it's to know that there is a lot of hope at this stage in life compared to where things were a long time ago. Cancer does not have to be a death sentence. It's still a very serious condition. But heart disease, it's just to all the cardiologists' credit how far that area has come in having such life-saving procedures. So if and when you get a diagnosis of something serious, have hope, because there's a lot of hope available. And to the doctors out there, I would say that in hindsight, going through the process, I was saying to my sister, who's a doctor, it would be so great if this information was more readily available, because I have like all these question marks in my head and I don't really know what I'm doing. And I was kind of panicking. And so to realize, to maybe remember that the information that you have as a physician, which may seem so commonplace to you because you're inundated with it all day long, especially for a person who's newly diagnosed, they may have a big blank. And so I think doctors do a great job as it is. And so just to maybe just help that person through the process as best you can, remembering that there are things that that maybe it seems like they would know, but they may not know. So I guess that's all I would say.
Definitely. How about you, Donette?
Oh, sure. One of the things that I would address would be or encourage patients to do is to know their family history. If there's cancer in your family, know about it, ask questions about it, and so that you can be aware of it and watch that for that. Like breast cancer, I had my whole family, all the women in the family had mammograms because I was diagnosed, and there have been several of my relatives who developed breast cancer just like I did. And so I think it's important to know your family history and what's in that family DNA.
Of course, thank you. And last but not least, let's hear from Dr. Russo.
Yeah, again, I would echo it's important to understand your risks, right? To make sure that you have a team of people who can appropriately risk stratify you and provide you the direction that you need based on those risks so that you can get ahead of any issues that you might face.
Thank you. Well, we are at time for today's webinar. I just want to thank everyone for taking the time out to join us today and learn more about this topic, as well as to our esteemed panelists who have shared a wealth of knowledge and information with us today. Please be sure to visit Heart Valve Voice US, our website, for additional information regarding echocardiograms, types of valve disease, and so forth. And we look forward to seeing you again on the next webinar. Thank you, everyone. Bye.
Thank you.
Thank you.
You.
Thank you.